Well, yeah, it's great to be here in person. I was here in the summer for launch on another wonderful sunny day. So great to be talking to you, and hello to everyone joining on Zoom as well. So how do we make sense of a pandemic? That's a question that I've been asking a lot over the last couple of years or so, as have many other people in my field around the world. And what I want to do today is talk through some of the ideas and data sets that people have used to make sense of what's going on, and crucially, what we might want to do about it. So perhaps to start, let's go back to the beginning. Let's go back to January 2020. And one of the big early questions was actually, what's going on in Wuhan in those early stages as cases appeared, and particularly mid-January. By this point, things were looking a little bit odd. 41 cases have been confirmed in Wuhan, and yet in those recent days, 3 cases have been detected abroad, 2 in Thailand, 1 in Japan. And if you think about it, if you have a city, most people are pretty unlikely to travel internationally on a given day. So if you've already detected 3 cases internationally, how plausible is it that you've actually only got 41 in the city? And what you can do is you can work out a reasonably straightforward probability calculation. You can say, well, if on average each person has this probability of traveling on a given day, if we've already spotted 3 cases internationally, how many cases do we think there plausibly are in Wuhan to be consistent with that international data? And that's exactly what Imperial did very early on, this kind of simple calculation based on flight patterns, based on what's detected abroad. And they estimated we're probably looking at just under 2,000 cases in Wuhan. Quite a lot of uncertainty, but a lot more than 41. And that was a crucial early signal suggesting that the situation we're facing could be very different from the one in just those raw case data. And this would actually be a signal that would indicate early on problems in a number of other countries. Iran, for example, the US, and actually the UK on the 9th of March 2020, exported cases were giving these early clues that actually these countries might have much more of a problem than the raw data were suggesting. And that raises the question in those early stages, in this kind of period in January, well, how likely is it we're going to contain this? How easy is it going to be to adopt these kind of SARS-like measures from 20 years ago successfully? And one of the reasons we face so many challenges for COVID was how transmission occurs relative to when people show symptoms. And so if you look at an individual who becomes infected, so point of infection on the left-hand side, for these early variants, people became infectious after around 3 days, would typically show symptoms after about 5 days. And then for a few more days infectious, and a few more days after that symptomatic. What that meant is that you could potentially have them infect someone else before they became ill with clear symptoms. And then that contact that they're infected in turn could become infectious. And so even if you identify the first case when they become ill, you isolate them, you work out who their contacts are, that might be too late to actually get in before that contact's become infectious. And that contact in turn might have infected someone else. I notice I just need to scroll down a little bit so you can see. I'm just going to zoom out a little bit so you don't get shortchanged on all of the science. So that's a problem here. So we're constantly having to catch up with the outbreak. And if you contrast that with something like SARS, where most of the transmission happened where people were symptomatic, SARS, that essentially shifts that timeline of contacts. So back in 2003, we were. There we go. So what we've done here is we've just shifted that timeline. So at the top, people are infectious when they're symptomatic. And you can see here, if we trace contacts at the same point, we're getting that contact isolated or into quarantine before they're infectious. And that's why SARS is much easier to contain what was going on. At the end of January in 2020, with some colleagues, we thought a bit more about the characteristics of COVID and the data that were coming in and what this might mean. And essentially, you can build a model around this process. So models have this reputation for being these complicated computer things, but what we're doing here is a model. We're just working through the logic of what we know about an infection and what it might mean for transmission. And what we can do is we could just simulate different individuals, different timings that they might be infecting others, and work out how plausible it is contact tracing would bring this under control. And what we found, if you look at the left, is just a kind of schematic of what I've just shown on the previous slides. But on the right-hand side, I draw attention to this curve on the bottom. So this sort of purple curve is showing what happens if about 30% of transmission occurs before symptoms. So we did a lot of this work end of January. So if anything, it was actually slightly optimistic on what we subsequently found out about COVID. But you can see that even if you're isolating cases quite quickly, so we made sort of plausible assumptions about how quickly you could identify people, you need to really detect a very large proportion of people's contacts. Because if you don't, as I showed on the last slide or two, you're going to get an outbreak that runs away from you. Because by the time you detect contacts, the few that are missed are going to go off and infect others, and then you're constantly having to play catch up with your outbreak. And that can get us into a situation where as the epidemic spreads, as contacts are missed, a lot of countries weren't tracing anywhere near this kind of level, you get this outbreak growing without necessarily awareness of that happening. And one of the key problems we face analyzing an outbreak in real time is delays. Because really what we want to do, if we want to understand transmission, we want to understand how things are spreading, we want to know when the infections are occurring, who's infecting whom. So on the left-hand side, you've got an infection event, but we rarely actually observe those events occurring, particularly in your early days with not fantastic data sets. Instead, we end up observing the downstream effects of those. So we might observe perhaps hospital admissions, or in some cases deaths. And actually, today is the 2 years since the first reported COVID fatality in the UK. But of course, that event is much later than when those infections were occurring. And an early signal in a number of countries, places like Italy and Spain, for example, when hospitals suddenly started filling up with COVID patients, you just have to look at this timeline and realize you've got a really big problem, because you're observing an event that occurs quite far after spread was happening. So you haven't got a problem now. You had a problem perhaps 2-3 weeks ago, and you've got all of that intermittent segment still to appear in your data. So this is, throughout the pandemic, been a real challenge for a lot of different countries. And early on, another big challenge was even just defining what you're talking about when you're talking about a COVID case. If you look, for example, in Wuhan, along the bottom here, this is dates in December coming into January. They actually changed their case definition 5 times. They started off with quite a strict case definition with very severe disease, really people who are kind of dramatically ill with COVID. And then over time, they'd not only update what they classified as a COVID case, they would also backfill. So they'd go back through their data sets and say, well, actually, these cases that we didn't think were COVID, we now do think were COVID, which in real time makes it really difficult to identify disease trends, because any meaningful comparison you might do, the data is actually shifting up and down as you go. And the data set you had this week might look different to exactly the same period in the previous week. So what can we do about it? Well, there's a lot of value, as we saw with that early imperial analysis, of thinking of ways of combining different data. So rather than just looking at this raw case data and all of the challenges with that, thinking, for example, of, well, how many cases are being detected in other countries? During that early period in January as well, a lot of evacuation flights were taking people out of Wuhan, and they were testing everyone on the flight. So even if you don't trust the data in the cases in Wuhan, you had these data sets from flights where they were just testing everyone. So you had these additional glimpses into what might be going on. And so we did some analysis during this period coming into early February with these different data sets, these sort of glimmers of reality, trying to pull things together. And what we estimated for the reproduction number, so this is the average number of secondary cases a typical infectious person is generating. I think this is something that's just really come to prominence in the last couple of years in terms of a number of people are looking at. We found that throughout most of December and January is above 1, so a lot of uncertainty you can see here, but if you look at the solid line, that's the kind of the average trend. And obviously, if each person on average is giving it to more than one other person, you're going to get this expected growth in your epidemic. But piecing together these different data sets, we found very strong evidence that when their lockdown came in, which is the red line, you got this really dramatic drop. And it suggested that that was predominantly the result of control measures. So by the end of January, we were estimating probably only about 5% or so of Wuhan had been infected, which at the time was quite a startling conclusion, because respiratory infections hadn't been controlled in this way historically to this level, if you look back at 1918 flu. But it was a way of pulling together these different data sets and trying to estimate what might be going on. And obviously, in hindsight, it's completely obvious what happened. We now have many other examples that indeed the measures that came in brought transmission down. You get initial, as I said, this reproduction number above 1. It peaked when it was equal to 1, so you're not getting any epidemic growth. And then it started to come down over time. I think for me, when we talk about mathematical models, this is one of the real uses of these. If we have fragments of data in real time, if we're trying to understand what's going on, they can be a way of just pulling together these bits of information. And a colleague of mine often points this Picasso quote that I think is quite relevant to when we're dealing with kind of data analysis and modeling. So this is, we all know that art's not truth. Art is a lie that makes us realize truth. I think the same is true of things like mathematical models. A model is not reality. The models I've shown you, what Imperial did, what we did, contact tracing, this is not the reality with all of its complexity. But a model is a simplification that hopefully gives us some insight into what that reality might be and what some of the factors might be that we might not have considered if we just looked at the raw data. And one of the key things that bringing together these data sets enabled us to do, and a number of other groups early on, so this is coming into sort of late February 2020, was estimate severity. Because if you think back to those early China case definitions, if you're just looking at severe cases, it's very hard to work out how many infections are fatal, because you're only looking at one small part of all of the people out there who could be infected. So even if you have measures on hospitalizations, measures on deaths, you don't have that comparator of, well, actually, how many infections are there? What am I dividing by to work out what the risk is? And so there were a couple of studies that used, as I said, these evacuation flights to get a sense of how much infection was genuinely out there. We did some analysis using the Diamond Princess cruise ship that had a lot of testing in that population. And then obviously adjusting, because Diamond Princess was an older population, so adjusting for the demographics, comparing to China. And actually all of these studies using different data sets, slightly different approaches, come up with remarkably similar estimates that if someone's symptomatic, even with mild symptoms, you've got about a sort of 1.2, 1.4% fatality risk. But crucially, we estimated, and there was some other analysis with flight data, about 0.6, 0.7% of infections being fatal on average in that early China situation. Now, there's been a lot of attention on complicated models and predictions and so on for countries needing to introduce measures. But for me, this was really one of the crucial bits of information to put together, because once you have a situation where 0.6, 0.7% of your infections are fatal, you don't need a big complicated model to tell you that if you have a large epidemic, you're going to be facing a really serious problem. So I think sometimes we can get, and certainly with the media, get distracted with the complexity of all these kind of modeling predictions. And actually, you can just use the back of the envelope and just say, look, once we know this number, you don't need a big complicated computer to tell you what you're potentially facing. But what models can do is they can look at a bit more nuance of, if different measures were to be introduced, what might that look like? And what generally happens when we're putting together these kind of scenario models is, first of all, we take the information we have. So as I've shown you, things like infection characteristics, when people are becoming ill, when people are transmitting, data on social mixing, which I'll talk a bit more about in a moment, how people interact, how different age groups have social contacts. We put this into a model of how people transmit. So like I showed you with the contact tracing, when are people becoming infectious, how many others are they passing it on to? And then we typically convert those estimates into what we know about infection fatality risk, hospitalization risk among those individuals, to move from a situation where you're tracking infections to one where you're tracking things that are actually going to put pressure on your health systems. So some early work that we did, this is sort of late February coming to March 2020, Imperial and other groups obviously doing similar work, found this quite depressing conclusion that there weren't really any light touch measures that were going to get us out of this. So if you look, I mean, here we've got cases in ICU beds, but the main point of this, the numbers are very big in many of these scenarios. And so it was very hard to see a scenario without very dramatic behavior change that wasn't going to overwhelm our health systems in this case. And one of the challenges, I think, in communicating some of these approaches, and it wasn't just in the UK, groups in many other countries, Australia, France, Singapore, were coming up with very similar estimates of what they were going to face domestically. But in some cases, we've seen this, I think, challenging reporting that people perceive these to be forecasts of us saying this is what's going to happen. I think one of the things we need to bear in mind is that epidemics aren't weather, particularly for something like COVID. I think a lot of our data experience of predictions and forecasts are things like weather, that if I say it might rain next week, you can see if it rains and you can see if I was right or not. But of course, for epidemics, if I say we're going to face a storm, and if you're in a situation where you could do something about that storm, that might change your attitude to it. So an example here is this quote from March 2020 from Angela Merkel. And she was quoted as saying 67 to 70% of the German population will be infected. So that's presented as a forecast. This is going to happen. It's quite sort of fatalistic. But she didn't actually say that. What she said was, if nothing changes. So a more accurate way of saying, well, they could become infected if we don't do anything. So in this is a scenario, because it's not saying, I think this is definitely going to happen. It's saying, well, this is what we could be facing. It gives us a baseline for what that could end up being. And this is important because, particularly if we're interested in how much susceptibility there is in our population, it's useful to have this kind of baseline, because as we saw, countries that introduce measures, if you've still got that susceptibility and you reopen, that's still a potential problem in the future. So it's really giving people a baseline of what they might be facing over the course of the pandemic. And obviously we saw many countries, as they reopened, face those challenges because of the potential hospitalizations they were facing at the start. But of course, we know people's behavior dramatically changed. But that raises the question, actually, how much did it change somewhere like the UK? And to do that, we need a baseline of what people's behavior was like pre-pandemic. And by a fortunate coincidence with some colleagues at Cambridge and the BBC, we actually ran a massive public science project in 2017-18, just under 90,000 people. Perhaps some of you might have heard of it or contributed, downloading an app that enabled people to record their social contacts and some elements of their mobility. And what it gave us a really useful baseline of what people behaved like in the year or two before the pandemic. What we could do, for example, is look at different social contacts. So here we have, along the bottom is different age groups, and then on the vertical is the number of contacts they make on average in different settings. Solid line is conversational contacts, dashed line is physical. So you can see for someone who's age 20 to 50, vast majority of their contacts is made at work. You see much higher peak in work contacts. Someone in an older age group, most of their contacts are made in other settings. So already this is giving some indication of why measures like working from home have had so much effect on COVID, because actually from a lot of those groups, that's where your volume of contacts is occurring. As you'd expect, lower on weekends, but still actually in terms of work environments, quite a bump in behavior. And what this did was give us a baseline which we can then compare what happens next. So in Wuhan, some contact studies found about an 86% reduction in average daily contacts after their lockdown. It wasn't quite the same in the UK, it's about 75% reduction, but still that's a phenomenal change in behavior. And actually the first signal that the UK lockdown was working and would bring the reproduction number down didn't come from case data or hospitalization data. It was actually social contact studies that were conducted in the few days after those measures came in that gave us a signal that behavior had changed enough to start to bring transmission down. So really, again, this idea of your delays in your data, having those early signals can be extremely valuable. We also see a situation in our BBC data of variation in contacts. So along the bottom here, you've got how many contacts people report. On the left-hand side, the majority of people don't report many contacts, but you get this handful of individuals who report a huge amount of different work contacts. I mean, actually, healthcare workers in particular were one group that stood out in our data set as reporting a lot of interactions at work. And what that can do in terms of your epidemic dynamics, if you have a lot of people who don't make many contacts and some people who make a lot, is you can have an epidemic which doesn't generate a lot of transmission. And then you get these amplification, these super spreading events when it gets into these individuals who have a lot more contacts than others. And we saw that in things like Hong Kong. So each dot here is a COVID case. The little arrows, which hopefully you can see, are transmission events. And you get these white circles. So you get a bar, a wedding, and a temple where there's this cluster where there are a lot of infections. You can see the bar on the left-hand side, one individual, lot of transmission. But you'll also notice a lot of these clusters on the right-hand side didn't really go anywhere. They kind of stuttered. You got one or two transmission events. And this is to some extent the paradox of super spreading, that if if you have this dynamic where there's a lot of variation in behavior, a lot of your outbreaks won't actually go very far because the majority of your population doesn't have many social contacts. But if it gets into these groups or these environments where there are a lot of contacts, suddenly you've got a much bigger problem that might seem like it's come out of nowhere. So often that can affect our interpretation of data, that it actually makes outbreaks less likely to spark initially. But when they take off, they really take off. And I think interpretation of early COVID data, this was very important because a lot of countries said, well, we haven't got a big outbreak yet. We've had a lot of introductions. It's all fine. And then very quickly, they had a very big problem. And it's this dynamic, this behavior that can explain how you can get into this situation. Now, one of the big debates, particularly in the media during 2020, why did COVID decline? And so I think there was an intuitive thing, if you believe in germ theory, that if people have less opportunities for transmission, that's going to have an effect. But actually, what are the contributing factors? And one of the challenges in answering this question is we need to think about, well, what influences a transmission process? What might bring down an epidemic? And what we can do to understand that is think about the different factors behind this reproduction number. So if you imagine a hypothetical infectious person, what influences how many others they give it to? Well, first of all, it depends on how long they're infectious for. If someone's infectious for a longer period of time, that gives them more opportunities for transmission. But it also depends on what they do while infectious. Do they have a lot of social interactions? How many opportunities are they creating for something to get across? But it depends as well on what happens during those interactions. Are people wearing face masks? Is it indoors, outdoors, ventilation, this sort of thing? And then finally, it depends on the susceptibility in the population. You could have an interaction, there could be some risk, but if both people are not susceptible, or particularly the person who's at the contact, you won't get transmission that you might have had earlier. So I like to call these things the dots for simplicity. So duration of your infectious, opportunities, transmission probability, and susceptibility. And very helpfully, if you multiply these steps together, you end up with the reproduction number. So in other words, if on average people are infectious for twice as long, you'd expect that to double your reproduction number. If on average you cut the opportunities in half, that's going to cut your reproduction number in half. But this also gives us a really big challenge in terms of explaining what's driving our reproduction number, because you can change one of these things or change another, and depending on how they trade off, they might have the same effect on R. So just to give you an example, what we can do is we can put together a simple simulation model. So it's a complete cartoon model, but here's one where the epidemic ends because you get a buildup of immunity. So in other words, the S comes down over time, and that brings your R down. So in this case, in the dots, what happens is as the outbreak goes on, susceptibility is coming down, and it's this sort of herd immunity type peak. But we can also build a model where there isn't much accumulation of immunity and just social behavior changes. Again, a cartoon model, but we can change the processes so that the reduction's all coming, or most of it's coming from reduction in contacts. Or we could actually build a model where contacts stay the same and there's seasonal effects. So maybe the environment's changing how the virus is spreading, maybe just the nature of people's interactions, indoor, outdoors, is changing. And we could build a model where it comes down because of seasonal effects. Now, the eagle-eyed among you have probably spotted all those curves look identical. And that means that actually, if you look at case data alone, you can't distinguish between these explanations. You can build a model that it's immunity, it's contacts, it's seasonal effects, and you can reproduce that case data. So what we need to do is we need to look at other data sources. We can't just look at cases alone. We call this the problem of identifiability, that with just this data, you can't identify which is the correct explanation. So for example, some work that people did, as I mentioned quite early on with social contacts, is actually looking at how these opportunities change, looking at actually measuring these social contacts. And certainly in 2020, the estimates of R you obtain from just looking at people's social contacts tracked really nicely transmission. So this is spring 2020 coming into the autumn. The red dots here are these estimates from these social contact surveys that I talked about a bit earlier. So you get contacts started increasing as things reopened in summer 2020. And then REACT is this community testing study run by Imperial College. That's a measure of infection. And you see this nice alignment in the dynamics between what's happening in community infections and what's happening in social contacts. So in other words, the contact data is giving you some indication. If it was all just immunity, you wouldn't expect these two things to be behaving in the same way. Another thing that people have done as well is look at when measures were introduced and when transmission was changing. It's particularly hard early on. So this is from 2020, different countries. Hopefully you can see lots of different icons, but the main point here is lots of things happened at the same time. Within a few days, lots of different things were closed. But over the course of 2020, as things reopened, as measures went in again, that variation in the sequence different countries introduced things allows some ability to try and distinguish what might be going on. And a recent paper did this and tried to estimate the effect on the reproduction number from these different kinds of interventions. So perhaps some of these are what you might expect, but one of the things that I think is quite striking is particularly on gathering size, there's very little effect actually on reducing transmission if you're putting constraints quite large. So to some extent, having a gathering limit of 20 or 30 is tinkering around the edges a bit. Because there's still quite a lot of transmission. Unfortunately, it's only in the situations where you've had quite strict measures where there's evidence here that those policies were having an effect. So obviously there's going to be other factors alongside this, but it's really an indication of how we might try and unpick this kind of problem. And it's a real big challenge, given particularly in spring 2020, just how much was coming in at the same time. And also this challenge of how to predict what might happen alongside these kinds of policy measures. And so to give an example of this, if we remember July 19th, so-called Freedom Day in the UK, some of my colleagues, as many other groups did, looked at different scenarios what might happen. So here we have Google mobility data. So Google are probably tracking all your phones and which environments you're going into, but they have these kind of summary measures of sort of grocery stores, retail, transit, and workplaces. And the black line is kind of what had happened over time. So you can see this kind of gradual relaxation last year in 21. And my colleagues looked at different scenarios. So post July 19th, what might happen? And they had a high scenario where everyone relaxes a lot. You had a sort of medium and a low scenario. And then made predictions of these different measures like admissions, deaths, peak beds. And they had two scenarios of if the vaccine didn't wane or the vaccines and immunity waned quite quickly. So you can see quite a lot of uncertainty, but trying to look at what these different behaviors might do. So this is hopefully a slightly easier question, given you all have the benefit of hindsight. But I'd just like to get a sense from you of who thinks post-July behavior relaxed substantially. So just a quick show of hands if you think actually after that point, people's behavior really relaxed. Yep. So a few. Who thinks that it was kind of mid, that it went a bit back to normal, but not huge amounts? Yep. And who thinks it actually remained cautious, or perhaps even got more cautious than it was before? Not so many people. So actually over this period, if we look from July up to about November, because obviously Omicron had big change in behavior, but over that kind of next few months, these arrows show where it landed. So actually on retail and recreation, it was kind of this middling scenario, so you're right. But actually on transit and workplaces, people were more cautious even than the most cautious assumptions in the model. So in reality, over this period, there were about 130,000 emissions. You can see it sort of landed between these two waning scenarios. But it illustrates that for these kind of approaches, we can generally get quite a good hand on how much susceptibility we think is still out there, how many people still are potentially vulnerable. But it's extremely difficult to predict what people's behavior might do. And I think what happened in July was people who were both for and against the reopening as a policy decision, both I think had this mental image of something that would go up and then sort of come down quite quickly. What happened in reality is this caution meant that we ended up with this very long plateau going through 2021, largely down to this behavior change and the scenario that it ended up putting us in. And obviously the emergence of variants, as I've said, with things like Omicron here, this was coming off the back of the Delta variant, is one of the big uncertainties still going forward. And so what can we understand about viral evolution? What are the data sets that we can use to make sense of them? Well, first of all, I think it's worth bearing some historical context in mind that SARS, there's some evidence in late 2022 when some clusters were pieced together from southern China. The reproduction number seemed to be lower than what it subsequently was when it caused large outbreaks. So it might partly be this super spreading issue that I mentioned, that actually just struggles to take off initially in certain populations, but also potentially evidence that it did pick up some changes during this period that helped it subsequently spread over those coming months. We now know, obviously, for COVID, that that's happened in reality, that we had, for example, the Alpha variant in December 2020, and these are a couple of headlines off some of the work that we were doing at that time to try and work out what was going on. And then the Delta variant as well, again, something that in hindsight is now completely obvious, but at the time trying to work out if you're seeing more transmission. We now know that COVID can pick up these changes that makes it spread more easily. But how can we piece together the relationships between these different viruses? So we have, you've got Alpha, Beta, Gamma, Delta, Omicron. What might that mean for their future? And so what we can do if we have different viruses is sequence them. We can look at their genetic code, and we can look at the relationship between different viruses to essentially reconstruct a family tree and try and work out how related these different variants might be. So just to give you a schematic of how this works, suppose today we detect two different viruses, we sequence them, we work out their genomes and work out the difference between them. And obviously, if those are quite similar, what we can do is we can look at what we know about the rate we would expect evolution to occur in those viruses. And if those differences aren't very big between the genomes, that would suggest that they've probably got some ancestor in the relatively recent past. Because in other words, they can't have accumulated that many changes over that time period. So if they're quite similar, it means it must have been quite a recent original virus that they both mutated from. If these two viruses have ended up a bit more different, then that suggests that they've had more time independently to go their own ways and transmit and mutate. So if they're a bit more different, we'd put that ancestor a bit further back in time. And what in turn we could do is say we get another virus which actually is very different to these two. Then we might estimate, well, actually based on that difference, it might have an ancestor even further back in the past. So essentially this virus is a sort of distant cousin of these two. So it's very similar to how a family tree works, that the further apart you put people on a tree, the more generations back you have to go to find a common link between them. Exactly the same idea, but we can use genetic sequences to do it. And what this allows us to do is understand when variants emerge, what are the different relationships between them. So if you think of this logic of, if you have these branches that are quite close in the recent past, that suggests that these things are more related. This is what the evolutionary tree looks for different variants. So a little bit to take on board here, but you've got Delta variant, so first identified in India, the Beta variant, then Omicron, the BA2 subvariant, which is sort of transmitting quite a lot of countries in Europe, Alpha, Gamma, and then the original variant. The horizontal period is just where samples are available. So you can see Delta first emerged in sort of early 21 and has actually been circulating ever since. Beta hasn't really been detected much since last year. But one thing hopefully that's quite striking is, first of all, the common ancestors of these things go really quite far back. So if you look at Delta, look for example at Alpha at the bottom, which was dominant in the UK in 21, and Delta, you have to go right back to the start of the pandemic to find a common ancestor for those things. So they've been spreading and mutating independently right from the start. I mean, there's uncertainty about exactly when that is, but it's not the case that Alpha was dominant in the UK and many other countries, and then Delta just emerged from what was already circulating. It looks like these things have been cropping up in many different ways. Omicron is another one. So Delta became dominant in many countries during 2021, but Omicron didn't emerge from Delta. Again, Omicron, if you trace back, you have to go quite far back to find an ancestor with Alpha, and even further back to find an ancestor with Delta. And in terms of evolutionary dynamics, it presents a bit of a challenge, because what we see for infections like flu is you have a variant becomes dominant, spreads within a population, you get some accumulation of immunity to that variant, then of those circulating viruses, you get something mutate that's a bit different, maybe immunity doesn't work so much. So the one where there's immunity against that virus, that fades away, then this new variant, this one that can escape immunity to some extent, dominates, and then you get this process continuing over time. But this process of kind of sequential virus replacement, we haven't seen in quite the same way here, because we haven't seen Alpha give rise to a Delta, give rise to an Omicron. Instead, we've got this situation where things have kind of popped up from much further back in the distant past. It's kind of like the distant cousin turning up to dinner that you just weren't aware of. And so if we're talking about what happens next, I think this is a particularly useful figure to bear in mind, because this pattern that whatever we're facing currently, the next variant is just going to come out of that. We've seen that a bit with the BA2. So Omicron, obviously the new variant that's spreading in Europe is most closely related to Omicron. But I think we should also just bear in mind that if we've got Delta circulating still in other countries, potentially there's still some surprises to come. And that brings us on, I think, to the big question of where next? Where do we go from here, given the data that we've got put together? And I think it's useful to go back to this framework of breaking down the components that influence the reproduction number. Because in 2020, a lot of the work in reducing reproduction number was this opportunities component, that people just massively changed their social behavior, and that brought down the reproduction number. We also saw features like in summer, people were outside, things like mask wearing, changing the transmission probability. But it's really those components that were doing a lot of the work. Now we've got a situation where initially vaccines were working very well at reducing transmission for things like alpha. So that was bringing down a lot of the transmission. And unfortunately for Omicron, we have seen just a lot of infections in a lot of countries. So actually it's that natural immunity alongside vaccination and things like boosters, which have been very effective in the short term, at least. It's the reduction in susceptibility from vaccines and infections that more recently has been doing a lot of the work in bringing down R, alongside some of these other measures. And so if we've got to a situation where it's the reduction in susceptibility, this kind of accumulation of protection from vaccines and infections doing the work, then what's really going to influence where we go next is what happens to that immunity. And so in particular, the characteristics of waning, particularly post-vaccination, post-infection, that's going to influence where we might be in a few months, what we might need in terms of future boosters. And then the other, as I've shown with virus evolution, the other component that's critical is going to be how these evolve to escape immunity. So whatever happens in terms of the next variant, are we going to see something which is slightly different to Omicron, a lot different? Is it going to spread more easily? Is it going to be milder, more severe? And I think given what we've seen with the characteristics of variants to date, that puts a lot of potential options on the table. But overall, I think these kinds of data sets illustrate that we're in a much better position than we were early in the pandemic. If you think back to those signals of exported cases, really noisy, patchy data, very, very rough indications of where we are. We now have much better data sets to track where infections are, to track where variants are, and allowing us to untangle these different components of where we currently are with transmission. And so really, for me, one of the big benefits of thinking in this kind of way and thinking about the process underlying is it can give us this much better understanding of what's going on, and then in turn, hopefully inform much better decisions about what to do about it. So with that, thank you, and happy to take any questions.
Thanks very much. Thanks very much for a great overview. Can I get in with a question first, and then give people a chance to think what they're going to ask? You mentioned very briefly the Diamond Princess, which was sitting in Yokohama Harbor for a time, and the numbers were going up. I wonder if do you know why did it take so long before they got people off the boat?
That's a good question. Trying to think back to the details of that. I mean, I think a lot of it was just messiness of infection control protocols at the time. That we saw with a lot of cruise ships, a lot of countries wouldn't want to take them because they didn't have big domestic outbreaks. I think from my memory, a lot of it was a mix of the geopolitics, but then also if you have hundreds of potentially infectious people, where do you put them?
Well, maybe in a steel box is not such a good idea.
Yeah, we saw that with a few cruise ships of that thing of leaving them on is clearly not a good outcome. But I think we saw even at international level with borders and other things, just a lot of messiness in decision making. I think a lot of those debates should have probably been had before a pandemic, rather than in the middle of a situation like that.
It seemed to take a long time.
Yeah. I think throughout the pandemic, we've seen a lot of things where getting those decisions and protocols in place have taken much longer, I think, than they need to, given the time pressure involved. So
there's another element in it, is that the decision-making delays.
Yeah.
Should we open up to other questions? Ruth was previously a consultant in communicable disease control and all sorts of things with the Protection Agency.
I'll take my mask off. Thank you very much. That was really fantastic. I mean, how you mentioned so much into an hour is just incredible. Thank you. What I'm interested in is your little model with your dots model and susceptibility. When you're looking at the impact of interventions, are you able to take account of the different level of susceptibility within populations? Because I had Martin Mckee, interestingly enough, talking about comparing what happened in Sweden with what happened in other countries, and someone was saying, well, what was what Sweden did right or wrong? And he said, you've got to remember that the Swedish population were in a much better position health-wise than populations in lots of other countries. So were you able to look at the susceptibility of the population? Was that a step too far in terms of modeling the impact of your interventions?
I think that's a good question. And it comes, so the DOTS is focused very much around transmission and kind of susceptibility to your ability to get infected and spread. But I think there's also that crucial component of how that translates into disease, and particularly severe disease. And I think we are seeing variation between countries in that. I mean, partly just an ability to handle it, ICU bed per capita and this sort of thing, but then also baseline health of populations. So that's something that we've looked at kind of top level. I mean, a lot of the work has focused on UK and then it's been calibrated to the very good sort of clinical data sets. But I think for those questions around places like Sweden, I think that, I mean, it's also that it's not just what happened during the pandemic, it's decisions made 10, 20, 30 years earlier that put the population in that position to respond. And I think for me, not enough focus has actually gone on that. I think there's a lot of focus on what happened mid-pandemic in terms of decision making, but I think we have a lot to learn actually about what was going on in the decades preceding as well.
It's a nice model. Are there any questions coming in?
There are some questions from Zoom. Anne Bennett asks, if there is virus sequence data, is this a zoonosis?
Shall I repeat the question? Is that useful?
Yes.
So in use of sequence data, if there's virus evolution, is there indication it's a zoonosis or a spillover from animals? I mean, those kind of trees can be very useful for piecing that together. I mean, we saw, for example, like with MERS, which is Middle East Respiratory Syndrome, a sort of previous coronavirus of concern, that if you plot the tree, what you end up with is the human viruses, but then camel viruses scattered amongst them. So if you imagine, if you've got transmission occurring from person to person, you would expect all of the viruses from that outbreak to be similar in terms of evolutionary history because they've been spreading within that same population. But if you have actually human viruses that are more closely related to camel viruses than other human viruses, that's an indication that you've probably got some spread between those different populations. So I know people are using it because there have been some examples of a transmission, for example, with the deer populations. And again, I think in some of those trees, it's how those viruses cluster can give you an idea of how much they're moving from one population to another.
Thank you. A couple more questions. Anne Chamberlain asks, what would you now advise the government and how would you ensure they are listening?
So I think, well, if where we are now, I think one of the big things for me is just to be aware of where the current uncertainty still sits and what the range of possibilities might look like. I think we've seen repeatedly in the pandemic, not just in the UK, I mean internationally as well, that it sort of looks okay, things are coming down and everyone just wants to pretend it's all over. And I think vaccines have done a fantastic job, and we do need a shift in our thinking, our approach, that we're not in 2020 mode anymore. But I think particularly within sort of government planning, we do need awareness of the possible range of variants that we could get. And I think that in the media and in many spheres, there's this idea of, well, Omicron was milder, so the next one will be milder and it will just get progressively better. But we know from Delta, we know from Alpha, you can get variants pop up with other characteristics. There's no evolutionary reason why you'd necessarily just get it endlessly milder. And so I think for me, if we were to get another variant, as we probably will in the next few months, what are the kind of decisions and the evidence base you'd need to do that? Or are we going to get something like with Omicron, where some countries panic and put border measures in, other countries think it's all okay, some try to lock down, some try to do this. And I think now's the time to be working out what we want to do when we get another variant of concern, which may or may not be as big a problem as some of the other ones.
I think that's it for the Zoom questions for now. Got any more in the room?
So a lot of interesting things coming up. But do you have any other questions at the moment? Is everybody beginning to think it's coffee time?
Give everyone a coffee to digest it, yeah. Okay.
How clear a correlation is there between the compliance of populations with lockdown measures and such up and the spread of the virus in those populations?
That's a very good question, yeah. And there's been a few bits of work come out of again, getting back to that question of where societies were beforehand, but things like the level of trust in governments and actually what you've seen, in terms of the same measures having an effect on transmission. I think particularly a number of countries that have had advisory type measures. And I think actually when you dig into it, it's sometimes quite surprising which countries legally mandated things versus just very strongly advised things. I mean, Sweden would be the classic example, but even between like Scotland and England, actually, if you dig down into what was legally mandated versus advised, there are some key differences there. And I think that the role of trust in governments is a crucial factor. And Denmark's a really interesting example recently with their reopening, and actually quite a lot of social sciences feeding in to what's the public's attitude to where they are, what their sort of risk profile is, and a lot of that feeds into decisions about reopening recently.
Can I take it from that you're saying trust goes in two directions? Government has to trust the people as well as people trusting government.
Yeah, I think throughout the pandemic, it's been that feedback process. I mean, to some extent, we see it with vaccines. I think one of the things the UK has actually done very well is I think we have very high levels of trust actually in our health institutions, combined with infrastructure for something like the NHS to be able to roll out vaccines. And I mean, Hong Kong's quite a striking example with their vaccine coverage in older groups, particularly early on with rollout of certain vaccines linked to trust issues around who was providing them, where the technology was developed. And I don't know if any of you looked at the data from Hong Kong in the last week, but they've now got by a mile the highest per capita deaths in the world because they didn't get the trust to get that coverage in the over 60, over 70 group. So
trust is therapeutic. Okay, sorry.
Thank you for the talk. I'm wondering, when you're talking about susceptibility, do you recognize different types of vulnerability? For example, I'm thinking there might be inherent vulnerability in certain parts of the population, so that increases susceptibility, but at the same time, there is like protocols like wearing masks and stuff. Do you recognize these as different categories? How do you put them into the model? Yeah,
I think that's a really important question. I mean, I think it depends a bit on the level at which we're trying to understand what's happening. So if we're trying to understand trends at a regional or national level, to some extent, as long as you're capturing the average across all of those groups, you'll get something that will be sensible. But obviously, when you go into the finer scale, having that idea of where those pockets are is crucial. I think one of the issues we still have, unfortunately, is when you go down into that finer scale in data sets, it becomes quite noisy quite quickly. And I mean, even pre-COVID, looking at something like measles, for example, that we had actually some quite large measles outbreaks in the UK because you had these pockets of lower vaccine coverage in certain groups. But one of my PhD students did some really nice work actually just looking at trying to correlate data on vaccine coverage at local levels with where measles outbreaks were occurring. And there didn't seem to be a very clear association. I think that's in part just because the data structures of where, someone registers with a GP, goes somewhere else, gets a vaccine, moves. But it's crucially important because I think we've seen throughout the pandemic, not understanding where those vulnerabilities are, and even just in terms of the messaging and sort of support for those groups, I think we need to be thinking about what we need to sort of set up to actually get those things put in place and get that sort of variation captured. So I think, the broad answer is it depends at what scale you're asking the questions, but I think particularly as you go more down to the individual level, and as we go forward, things that you might need to put in place for groups. I think making sure we're collecting that data is going to be key.
We have two more from Zoom.
Okay.
1 second, I just need to scroll up in the chat. From Alison Shaw, asking, there are news reports saying people are being reinfected with Omicron. How would reinfections impact the data modelling going forward? Yeah, so for other people, that's a question about reinfections for Omicron. And I think if we go back actually to this tree, BA2 is dominant now in a lot of places in the UK. So although BA2 is categorized as Omicron, what we're seeing is probably reinfections with slightly different variants. And if you think back to this idea of susceptibility, it means that people who might have got an Omicron infection built up quite good immunity. So if it was that same exact variant coming back, probably quite good level of protection. But it's now that we've got a subvariant, which is increasing the potential susceptibility to infection. But in many cases, those reinfections are going to be much milder because you do have that similarity between these viruses. So I think if you look at something like flu, for example, it's actually remarkable how many people get infected in a year. There's this wonderful study from South Africa where they sample people like twice a week, and they found about 40% or so of the population got flu every year. And there were a lot of flu reinfections within that season. So it didn't mean people get like really ill and bedridden with flu, but essentially if you look hard enough for it, you can find these reinfections. I think this is what we're seeing at the moment. And obviously working out at the population level, are these things a big problem? And the ONS data that came out yesterday suggests that BA2 is tapering off in some areas. So it might be that there's some potential to reinfect, but it can't actually grow rapidly within the population. But I think that's going to be the key question, is that what do these reinfections ultimately do over the next few years? Another question from Ruth Anderson. Have you done any modelling on Africa? So we've done a little bit. I mean, a lot of the works that we have done have been in collaboration with some of the great groups there, like Sosima, that's in South Africa, based in Stellenbosch. They did a lot of work on Omicron and Beta. And I think there's a bit of a balance in global health, that obviously we've got a lot of modelling capacity, but I think it makes sense for, where possible, a lot of that work to be done by obviously the groups who have better local expertise. What has also been done, though, from a number of colleagues, is not just modelling of what COVID is doing, but actually just evaluation of the impact. So if you look at a lot of countries, very few reported cases, but in part because you need a test to confirm it as a case. If you don't have any tests, you're not going to have any confirmed cases. So some colleagues have done work, for example, using machine learning on burial sites in places like Somalia and South Sudan to actually look at differences in mortality. And actually some of these cities probably have among the highest excess mortality in the world, but you wouldn't see it in any public data set, just because a lot of these don't have like routine systems for births and deaths. So all the things that we kind of take for granted, that these things are recording, going to NHS systems, actually just documenting, modeling aside, just working out what actually happened is going to be a big question for a lot of countries. And a question which I think correlates with this one, the last one, from Anne Chamberlain again. Madagascar is very poor, with poor infrastructure, poor health structure, poor PPE for health staff. Will it act as a reservoir for the world, and what to do? Yeah, I think there's probably a lot of countries that are in that situation. There's quite a few that we've seen, as you said, with limited ability to kind of have those protective measures, and in some cases limited control measures. And when you do antibody studies in some of those countries, you actually find very high levels. I mean, a lot of sort of sub-Saharan Africa, you find sort of 70-80% plus, and a lot of that will have come from infection. I think my view is, given the amount the virus has changed from what the vaccines were designed for, it's going to be very hard to stop transmission fully at a global level. But I think we do have to prioritize deployment of vaccines in a way that's going to protect those risk groups. So particularly if you've got countries that are facing big Omicron waves, I think it would just be ridiculous that roughly 18 months after vaccines were becoming available, we haven't got those into the, at least the older groups or the risk groups, those populations. There's also something to be said as well, that if you look at Omicron, that came really sort of out of nowhere from the distant past, and one of the best theories for that is that it might have been someone who was chronically infected. So you had someone who
essentially the virus, essentially if you get a long line on one of these trees, it means you've missed something, because if you imagine, if you had the view of everything that was going on, you should have much more of these kind of viruses that you can fit together. So what may have happened is you have someone, perhaps immunosuppressed HIV patient or something like that, where the virus isn't cleared by their system, it's being repeatedly challenged by the immune system ineffectively, and that puts a strong evolutionary pressure on it to pick up those changes, and end up when it emerges is dramatically different. So I think particularly for those populations, just from a global point of view of protecting ourselves from future evolution, working out how to make sure that those groups as well are protected in those countries, I think would be very helpful, given we've had several instances of new variants emerge, not from the dominant outbreak in somewhere like the UK, for example, but it actually seems to be potentially immunosuppressed individuals who are chronically infected.
I believe that is it from Zoom.
Should we let people get a coffee?
I think as you bring it to an, there's still quite a lot more of this story to be told.
Yeah, and I think we're getting out of, I mean, one of the ways my colleagues put it is we're getting out of emergency mode. We were never going to be in emergency mode forever, but a lot of infections, if you look at HIV, if you look at even things like malaria and TB, still cause enormous damage worldwide. And they're not on the newspapers every day, they're not pandemics, but they're still there. And even in the UK, I mean, I think a good example is things like sexually transmitted infections. People still adapt their behavior and think about treatment and think about things around them. So it's not that we just pretend they don't exist, but they've become more manageable and more into the background. I think that's the sort of transition that we're currently going through with COVID.
I think if we can say thank, I think if we can just say thanks very much in the usual way.
Good morning, and thanks for inviting me to give this lecture today. I'm really sorry that I can't be with you in person. Now, you'll see that I've changed the title of the lecture ever so slightly, because, as will become apparent, the threats that we face in the future are more than just controlling microorganisms as they cross borders. We need to understand how they cross borders, what makes it easier for them to do so, and what are the conditions that allow them to spread within populations. Let me start by explaining where this comes from, the work that I'll be talking about today. About 2 years ago, I was invited by the WHO Regional Director for Europe, Hans Kluge, to join the Pan-European Commission on Health and Sustainable Development, with a subtext in the light of the pandemic. The Commission was chaired by the former Italian Prime Minister and European Commissioner Mario Monti. And the members of the Commission were not the usual suspects that you might find in a discussion on health. They were drawn primarily from politics, from finance, from other sectors. So we had 2 former Prime Ministers, Mario himself and Helle Thorning-Schmidt, the former Prime Minister of Denmark, 3 former presidents from Finland, Estonia and Kyrgyzstan, people from central banks, as I've mentioned, from the Food and Agriculture Organization, and elsewhere. In the UK, we had Lord Jim O'Neill, who will be known to many of you as the person who created the acronym BRICS. And I was also privileged to chair the Scientific Advisory Board for the Commission, and I've included a picture of the report that I produced to inform their work. And what I'm going to be talking about is very much drawn from that report. If you want to read it in more detail, just Google Monti Commission and you'll be able to download it all from the WHO European Region website. The starting point was to understand what went wrong in the pandemic. An analogy that I and colleagues have used previously is that a country going through a pandemic is like a ship in a storm. A group of countries are like a fleet of ships going through a storm. And the challenge is how to get through safely to the other side. So if that's going to be the case, how are they going to do that? What are they going to need? Well, first of all, they're going to need a captain, a prime minister, a president who can provide decisive leadership. And we want the captain to be on the bridge of the ship when the storm is there, not somewhere else. For example, sorting out their personal problems or other policies, missing key cabinet meetings, for example. And we want that captain to understand the science, to understand how the winds blow the ship through the sea, how the storm behaves, how you make sure that the ship is sailing on the right course. So you need somebody who, for example, does not think that you can cure COVID with ultraviolet light or bleach. That's the first thing. We need a really competent captain who is paying attention at all times. The second thing that we need is a crew that is well trained and working together, speaking the same language, understanding each other, so that when an instruction is shouted out, everybody knows what to do. We don't want to get into the storm and find that we have no crew, or that we are deficient in numbers, and we have to go to an outsourcing company to find them, as we have so often done in the United Kingdom, where we go to companies like Serco or Group 4S or whatever. You cannot go to find trained people who can work together in the middle of a storm or a crisis like a pandemic. You need to have ships that are seaworthy, in the same way that you need to have countries and societies that are strong and resilient. We do not want crew members falling through holes in the deck. In the same way, we do not want our fellow citizens to fall through the gaps in the social safety nets. We want them to have the security they need to isolate when they become infectious without losing their income, without having to choose whether they isolate or they feed their family. We want them to have the security of knowing that they will have a job to go back to. Now, of course, the furlough scheme that we had in the UK did this quite effectively. It wasn't as generous as in some other countries. But of course, going forward, we don't have the sick pay, the value of sick pay that other countries do. In Germany, when you are sick, you get 100% replacement of your income. We get about 19% on average. So you need to have those all of the things that are in place to protect you against all of the other risks. Strong education systems, schools that have got all the facilities they need, children that have access to laptops, all of those things which create resilience in a society. Now, of course, no country is an island, not even the United Kingdom, maybe 2 islands, but of course it is connected to the rest of the world. And we know, and Adam will have described how cases were moving across borders. So we need to have a communication system so that countries and ships can talk to one another. Now, this was a particular problem in the United Kingdom. And I know it will be contentious among some members of the audience, but I can tell you that Brexit made it a lot more difficult. So there were a number of occasions when information was not transmitted between some of our neighbours and the United Kingdom, because we in the UK had said that all contacts had to be at ministerial level rather than the level of officials. And that led to a number of problems, like when France was put on the Amber Plus list, when a simple phone call would have made it clear that in the United Kingdom somebody had misread a graph. You need a lookout, you need a surveillance system. Again, Adam will have talked a lot about this, but we need to have a system that is in place to look at what is coming over the horizon, to see the storm clouds in the distance, and to see where the calm waters are that we're heading for. And the captain needs to have a chart. They need the right chart. And in this case, they needed a chart labeled coronavirus or SARS, not a chart labeled influenza or Ebola. And the problem in a number of countries was that we were working off the wrong chart. We were assuming that the virus we were dealing with would behave in the same way that others did. We failed to recognize the importance of airborne transmission. We engaged in a lot of theater around cleaning, washing hands and things like that, which is fine. We should be doing that anyway. But the problem was that we failed to then do the things that were necessary around mask wearing and around ventilation. So all of those are the things that we need to get through a pandemic or for a ship to get through a storm. Now, as we look forward, we cannot ignore the fact that we're not going back to the situation before COVID. The world has changed, the world has moved on, and that will shape how we respond to anything else in the future. What does that mean in practice? Well, our health services will have to adapt. We will have continuing outbreaks of COVID with new variants. We were fortunate with Omicron that it was milder than Delta. But as NERVTAG, the group that advises the government on new and emerging respiratory viruses, has pointed out, that was just good luck. We may not be so lucky the next time. The next variant may be a lot more severe and it may be able to evade the vaccine much more effectively. We are going to have a major problem dealing with the legacy of long COVID. We can debate the precise figures, but it is clear that a significant proportion of people who get COVID go on to have long-term consequences, some of which may not become obvious for some years to come. In particular, the impact, the effect of damage to nervous tissue and the heart and cardiovascular system. We have the legacy of mental illness, and we absolutely needed to impose restrictions to prevent the spread of the virus, but there was much more that we perhaps could have done to prevent the mental illness that was associated with the loneliness and isolation that came with that. Our health systems will be different. We've got new ways of working, new models of care. General practitioners have been criticised for reducing the number of face-to-face consultations, but as we have shown in the United Kingdom, their overall workload has gone up dramatically because they are now seeing many more people online. And people, it may not be everybody's experience, but if you look at the data, people are finding it easier to get an appointment. We're going to recognise that we need surge capacity. We cannot go on as we always have in the UK, running our hospitals at 95, 98% occupancy. Other countries don't do that. They recognise that there will be some spare capacity. They don't call it waste, they call it taking precautions. And we will see much more team working. Now we're going to need that for long COVID because we will need the multidisciplinary teams working together because it is a complex multi-system problem. But in all sorts of other ways, we have seen the heroes in the National Health Service come together to change the way that they work, to work together in new ways. Otherwise, we would have been overwhelmed, particularly because we had such limited intensive care capacity. Our schools are going to change. Hopefully, we will see better ventilated classrooms, but we're also seeing new ways of teaching online, using information technology in a much more appropriate way, given that is the way that children will be working as they go through their adult lives. What about the economy? Well, of course, this, when we wrote our report, the International Monetary Fund was being very positive. Things are maybe a little bit more complicated now with rising inflation, supply chain problems where, of course, the United Kingdom is already being particularly badly affected. You just need to look at the film footage from Dover because of the problems there. And of course, although we're now growing rapidly, the hit to the economy that we experienced was much greater than other countries, so that we still haven't recovered to the degree that they have. But as we go forward, will everyone benefit? Because we know that a lot of people did very well, or a small number of people did very well indeed out of the pandemic, but a lot of people did not. What will be the situation in the built environment? Well, hopefully we will have improved ventilation. People will be working more from home, so they may look at whether they need to create home offices if they can. People are making decisions about where they want to live, moving out of cities, for example. How will our work change? Almost certainly quite a lot. We're already spending a lot of time on Zoom. Do we need all those meetings in person? We need some of them, But that has consequences too, particularly in terms of younger people who are developing networks. And we're seeing a fundamental change in the role of the state. In the past, government said we shouldn't intervene in the economy. If we need something, we'll buy it, often from China. But now we're seeing real problems with supply chain management. So we're seeing the government intervening in a way it never would before, as we saw with Oxford AstraZeneca vaccine. The Oxford team originally wanted to work with Merck, but the government said no. They had to do it with AstraZeneca because it was a British-Swedish company and they wanted to make sure that there would be supplies of vaccine. Now, that would not have happened in the past. And we're seeing a reassessment of the rights of the individual versus the rights of others. We wear face coverings to protect other people, mainly, a bit to protect ourselves, but it is part of showing our reciprocal solidarity with our colleagues, balancing our rights and our obligations. As we go forward, I think what we're going to see is that people are making the case for health much more. And we're seeing politicians from across the political spectrum in other countries and ones that perhaps had not really placed such a high priority on health, recognizing that they need to do so going forward. So what are the arguments that a government should heed when it looks at its approach to health? Well, the first thing is, of course, that it's the right thing to do. The golden rule, which we find in all of the major religions, is that you do unto others as you would unto yourself. And that means that we collectively contribute to the resources that are needed to prevent other people suffering or becoming ill. Fundamental philosophical principle. But there are also reasons for investing in health, partly out of altruism, it makes us feel better, but self-interest. It was always thus. If you go back to the Victorian period, the leaders of the cities then would build what they then called lunatic asylums and fever hospitals, not because they were necessarily concerned about the people who were in them as patients, but because they wanted to stop the spread of infection from people who were infected to others, or they wanted to confine those who had serious mental illness lest they harm others. That was self-interest. But the combination of altruism and self-interest are strong enough to justify health in its own right. But we need more than that. Health is a human right. It's there in the Universal Declaration of Human Rights. The International Covenant on Economic and Social and Cultural Rights talks about the right to health, and all governments, including our own, have committed to a minimum level and progressive realization. So as we go forward, we should be doing more to invest and promote health. And our government and all of the others across the world have signed up to the Sustainable Development Goals. So health is there. Our political leaders have committed to better health. It's up to us to hold them to their commitments. But of course, that's not enough to convince them all. Health is a driver of economic growth. Now, some finance ministers, but by all means not all, take the view that we shouldn't be spending money on health, or we should minimize what we're spending. And we saw this very recently in the discussion between Rishi Sunak and Sajid Javid about the bill for testing. But previous finance ministers like Gordon Brown, who set up the Wanless Commission, or finance ministers in many other countries, recognize that by investing in your people, the health of your people, you increase their participation in the labor force. They don't retire early because of ill health. They work longer hours each week. They're more productive when they're at work. There is lots of evidence on this. That was why the European Union talked about health is wealth in 2005, following a report that I and others contributed to. But there are also other arguments. Health and security. It is the first duty of a government to protect the lives of its people. And of course, that is precisely what governments are doing across Europe at the minute. That is why the governments of the Baltic states are asking for help, the government of Ukraine. So if you're going to protect your people from an external threat through conflict, then the same argument applies to protecting your people from a threat from a microorganism. And perhaps, to my surprise, actually, in our discussion, one of the most important arguments that we were hearing from the politicians was the issue of health and solidarity, because it has now become clear that people who are being left behind socially, economically, and particularly in health terms, become desperate, and they look to anybody who will offer them the promised land, offer them something better. Now, we've recently published a paper where we looked at the death rate in Italian cities in 1918 in the flu pandemic and showed how it was correlated with the vote share that Mussolini got in the 1924 election. We have done similar work showing how worsening health at local level in the Weimar Republic was associated with the later increase in vote share for the Nazi Party. Now, I'm not stretching the analogy from those particular episodes to the present, but I would simply note that my colleague Jacob Bohr has shown that the counties in the United States where life expectancy fell most were the ones that changed from voting for Democrats to voting for Donald Trump in 2016. And we have shown the same in England and Wales, with worsening health in the period following the global financial crisis and the vote for Brexit. So we see how communities that are being left behind provide fertile ground for those politicians who advocate division and hatred. But as we go forward, we need to anticipate what comes next. And it could be anything. Some of you will have seen the movie Don't Look Up, an asteroid strike. We also, and I thought we would never be saying this, but we also know that the Russian forces have been doing nuclear drills on the borders of Ukraine. And this time, let's hope that Vladimir Putin is not serious, but we really don't know. But we've also seen cyber attacks again on the Ukrainian government recently. We're living in a very uncertain world. We'd like to think that we'll get through everything, but the historical record reminds us that we may not. Some of you will have read this book, Collapse, by Jared Diamond, and he presents us with lessons from history of civilizations that collapsed when they failed to adapt to often environmental change. The Vikings who had settled Greenland, who failed to learn from the Inuit around them. The inhabitants of Easter Island. The Polynesians of Pitcairn Island, who died out only for it to be resettled by the survivors from the Bounty. The Asinesi of southwestern North America and the Maya of Central America. So there have been many societies that have failed to adapt, failed to respond to threats, and unfortunately, in many cases, they're no longer around to tell the tale. So if anything can happen, from an asteroid strike to artificial intelligence out of control, we need a comprehensive approach to threats to health. And this is what we did in the report. I've tried to pull this together a bit more in this diagram here. So when we look at the determinants of human health, we have your genes, gender, ethnicity, your migration status, your socioeconomic status. All of these are important. In animal health, we need to look at the health of domestic animals and of wild animals. In our environment, we have the natural environment, of course, and that's our relationship with, for example, pollinators like bees and so on. We have the built environment, which shapes powerfully our behavior. Do we have green spaces around us? Our social environment, our social networks. Trust has emerged as so important in the pandemic. And of course, we have microorganisms, leading to new infections, re-emerging infections like tuberculosis, and above all, antimicrobial resistance. So we put all of these at the middle of our diagram, and then we look at the other things that can happen. Now, some of these are at a planetary level. Volcanic activity, as in Tonga recently, An asteroid impact, let's hope we don't have that. Earthquakes, tsunamis, geomagnetic storms from the sun, which could wipe out all of our satellites. There are the things that we do ourselves to the planet. Global warming, deforestation, loss of biodiversity. But then there are all the other things that are the prerequisites for health. Now, in the 1980s, government signed up to the Ottawa Charter for health promotion. And it basically said the first prerequisite for health was peace. Peace and security. And we can see in an uncertain world how we can never take that for granted. But then there are the other things that the public health champions of the 19th century talked about. Clean air and water, safe and nutritious food, warm, secure housing, education. And more recently, we've realized the relationship between employment and working conditions. Health and safety at work, often attacked, but remember the conditions in the dark satanic mills in England of the 19th century, the days of sending children up chimneys. Thank heavens we've left that behind us in this country, but we haven't left it behind us in many other parts of the world on which we are dependent. The sweatshops that provide the cheap clothes that we wear. We're recognizing more and more the importance of healthcare. It's really making a difference. The achievements of science. The management of a condition like a heart attack has been transformed since I was working in a hospital in the 1980s. Social networks and trust above all. Trust is crucial in our response to a pandemic, and in a recent study it emerged as perhaps the most important factor in how some countries did better than others. And digital access, come back to that in a minute. Safe environments and access to justice, I'll say something about that too. But then there are the things we can do that make things worse. Conflict and terrorism, of course. Pollution, we know that levels of air pollution were closely associated with outcomes from COVID. People who had damaged lungs were more vulnerable. Food insecurity, we showed how a lot of people in the United Kingdom who were already dependent on food banks, that number went up. More people were facing food insecurity during the pandemic. The homeless, people who are suffering from, are experiencing informal, irregular or unsafe employment, who cannot take time off to isolate. The threats from harmful commodities. In some countries, smoking rates went up during the pandemic. Hazardous drinking did too. The threats of cyber attacks, hostile artificial intelligence. Remember that the Irish COVID surveillance system was taken down by a cyber attack. The risk of disinformation and fake news, and haven't we had so much of that? People promoting quack cures like ivermectin and chloroquine, but also the anti-vax information that has been circulating so much. Crime and corruption I'll come back to, and we know that the impact of the pandemic has been so much greater on people from minority ethnic populations. The racism and the xenophobia makes things worse as well. A reminder that there are some things we can do nothing about. These are pictures from a few weeks ago from the volcano near Tonga and the devastation that it caused in an island that had actually come through the pandemic, or an island group that had come through the pandemic relatively unscathed. As we look forward, we can see that biodiversity is our ultimate insurance policy, and yet we are damaging this all the time. The government is looking, British government is looking at ways of relaxing some of the regulations on, for example, pesticides, with potentially damaging consequences for the bees that pollinate so many of our foodstuffs. I do need to give the government credit for its support for biodiversity in other parts of the world, for example, with the British Armed Forces supporting anti-poaching patrols, but we need a joined up strategy here. And a report written for the government recently showed that this has a tremendous financial value apart from anything else. But what about some of the other things? I mentioned conflict, and that we've seen how conflict has allowed COVID to spread in a number of parts of the world. Digital access, the NHS app. But we forget that even today, there is a very high proportion of the population in some parts of the country who don't have access to the internet, who don't have broadband at home, who cannot afford the data on their mobile phones. And it became clear that that was a major factor in the uptake of testing in the work that was done in the very interesting studies undertaken in Liverpool. I talked about crime and corruption. One of the least good things about the UK's response, and the UK has done well in some areas, but of course overall has not done well, has been procurement of PPE and other things. The VIP lanes, the fact that about 80% of PPE procured through the normal channels was used, less than 20% through the VIP channels was used. The way in which people were able to get links to ministers through peers and so on. This is, I think, a matter of deep national shame, and it really should never happen again. I was the rapporteur on a European report on procurement, and I have to say, compared to our European neighbours, the UK did not come out of it well. The next thing we want to consider is the way that COVID has exploited existing inequalities. So this is a map of the initial phase of the pandemic, and you can see where the death rates were highest, the darker areas across England, and you can see that they correlate closely with the index of multiple deprivation. COVID was very much concentrated in the most deprived areas where you had multiple generations living within a household, where people were living precarious existences, were in public-facing jobs where they couldn't work from home, where they couldn't isolate, where they didn't have broadband at home, and so on and so forth. So this also has implications for our response, because although the British government did do relatively well in terms of ramping up its testing initially, of course it had huge problems with the contact tracing service, which we might talk about later. But the weakness in all of this was that you really need an integrated approach. And where we had problems was with the ability of people to isolate and support and to gain support for when they were isolating. That was the real challenge, and that was where many of the weaknesses arose. This was a diagram that we produced for a paper where we looked at the many challenges in pulling together a comprehensive testing and tracing response. It's not just making tests available. It's not just having a phone system service that you can call up when you have a positive result. It is a lot more than that. So moving forward, if we are going to prevent the spread of infectious disease, we need to find ways of healing the fractures that weaken our societies. Now, at an international level, which was where we were looking, we need to create internationally comparable information systems that capture the many inequalities in health and the inequalities in access to care within and among populations. We in the United Kingdom actually do quite well in one area, and that is our ability to capture data on ethnicity. The Scandinavian countries can also do this, the Netherlands can, but a lot of other countries don't, partly because of sensitivities that go back to the 1930s, whenever data on, in particular, religion then was used for very tragic purposes. But we also need to find better ways to identify people in society who lead not just impoverished, but precarious lives. Because we can talk about rich and poor, but the reality for many people now is that they may be coping most of the time, but then something happens and they fall through the cracks. It's the precariousness of not having enough resources and money in the bank to tide you over if you can't go to work, or if your car breaks down, or if you need some repairs to your house or something like that. It's the insecurity that has implications for so many aspects of health. We desperately need to look at that, because that is part of the resilience in a society in the threat of infectious disease, or in fact any other natural or unnatural disaster. Let's come to the science. Again, somewhere where the UK has done really well. The recovery trial, a world leader, which demonstrated that chloroquine was not effective, that steroids were. And that was because with a unified National Health Service, and the National Institute for Health Research, it was possible to put in place large-scale clinical trials. Now, in an ideal world, every patient being treated for a condition where there is where we still need new treatments or there is any uncertainty about treatment should at least have the benefit of being offered to participate in a clinical trial. We know that people who are invited to be in a clinical trial do better even if they get the control substance. So therefore, clinical trials are really at the heart of providing modern healthcare. And we do it quite well. Always ways in which we could do it better, but we do it well. The open safely system, the data that were used when you collect when your medical records are recorded. And we really shouldn't underestimate the huge value that that had. Sometimes people get concerned about privacy. Of course, I understand that. But the other side of that, I would personally argue that when you receive healthcare from the National Health Service, you have a responsibility to contribute to generating the knowledge that other people did in the past to help you and which will help other people in the future. And of course, the vaccine, where the United Kingdom can be very proud, and also of the huge effort by people in the National Health Service to get that initial rollout going. Of course, we have not done well since then, but the initial rollout was really excellent. Another area where we've done really well and we can be proud is the genomic surveillance. 20% of all samples are sequenced. This is one of the highest in the world, much better than in countries like the United States. But what do we need to do with science going forward? Well, we need to do much more. We need to look at the way in which we undertake research. Because at a global level, we still have neglected tropical diseases. We still have gaps in our knowledge about the health of some populations. The visible, some migrant populations, for example, some of the poor living in rural areas, for example. And we need to really think much more about being proactive in developing our research agenda so we don't have neglected tropical diseases anymore. Of course, the public sector and the private sector need to work together. The pharmaceutical industry is an important partner, but we need to rebalance that relationship because at the minute, in so many areas, the government, you as taxpayers, are paying for the research and development which delivers new medicines. That's good. But then you're paying again to buy the products that were developed from that research. So as governments invest in pharmaceutical technology, then they should get some of the rewards of it as well. And we need to do much more research on how to implement innovations rapidly. The UK does well in this, but again, we could do better to make sure that as evidence becomes available, it's put into practice. And we make a lot of recommendations for how this can be done nationally and internationally. Let's come to the health service. The NHS did cope during the pandemic, but only just. And in some parts of the country, it was effectively overwhelmed. My colleagues who worked in the wards were absolute heroes. Yes, we all went out and clapped for them. Unfortunately, as in the soldiers in the First World War, maybe we're forgetting about them now as we look at their terms and conditions going forward, but that's another story, probably not surprising. What do we need to do going forward? We need resilient health systems in the same way that we need resilient societies. We need to increase investment in health systems. Now is not a time to be cutting back. We need to invest in and strengthen the health workforce, and that is going to be a big challenge because for years the United Kingdom has depended on people coming to us from abroad. It's in those circumstances, it's really not a good idea to create a hostile environment. And as we've seen, recruitment from the European Union has dropped off a cliff since 2016, hardly surprising in the circumstances. We need to do much more to bring health and social care close together. And we need to prioritise prevention. But how are we going to do this? How are we going to get the money to invest in health? Because we know that when health ministers go to finance ministers, if they get an appointment to see them at all, they are rarely welcome. And we make a number of recommendations about this. The first thing we need to do is that investment in health is investment in our future. It's investment not only in the health of our nation, but in the prosperity of our nation, for all the reasons that I've said. And in the same way that we look at investment in education as being good for the country, or investment in physical or digital infrastructure as being good, we need to have accounting systems that recognize the investment in health. We need to incorporate health into economic forecasts. So if we have a government that is not prioritizing health, then when the OECD or the International Monetary Fund come along to do an assessment, they should say, by not investing in the health of your people, you are placing your economy at risk. We cannot give you a clean bill of health for your economic policies if you haven't put in place the means of protecting health. And that's particularly an issue for the Article 4 consultations that the International Monetary Fund does for countries. We need to invest in what we call global public goods. Now, public goods are things that need to be there, but once they're there, you cannot stop anyone from benefiting from them. And you cannot easily charge an individual from getting them. Street lighting is a good example. You can't have a system whereby the light only goes on when somebody who has paid for that lighting is walking past, although with modern apps, who knows in the future. Now, things like getting high levels of immunity in the world, investing in vaccine equity, for example, so we don't have new variants emerging from other parts of the world. Those are the global public goods, and we can't leave that to the market. Governments have to do that themselves. They need to make a conscious decision, and that needs to be factored into our economic models. And that means that we need to increase our share of development finance. As many people have said from all sides of the political spectrum, most notably the Conservative MP Andrew Mitchell, a former International Development Secretary, has pointed out, cutting your international development budget from 0.7 to 0.5% is really, leaving aside the fact that it breaches a clear manifesto promise, it is just not in our own self-interest to do. But we need to have a global governance system as well. And that means finding new ways to work together. Now, in our report, remember that we did have Lord O'Neill, Jim O'Neill, who'd been influential in the recovery from the global financial crisis, Sylvie Goulard from the Banque de France, similarly, and they work closely with Mark Carney, who has written an excellent book called Values, which is in many ways a public health textbook. What they did after the global financial crisis was to set up a global financial stability board. And the Financial Stability Board was what got us through the pandemic without a financial crisis. It put in place rules for liquidity of banks. It put in checks on their ability to withstand shocks. And it provided a basis for them being much stronger as they went into the pandemic. Now, we have argued for something similar to health, something that will require countries to have resilient health systems so that when a shock comes, they can withstand it. We need a new pandemic treaty, one that holds governments to account but supports those in need. You cannot have a situation where one country fails to respond to infectious disease and thereby allows the infection to increase and to spread to other countries. There is a reciprocal responsibility here, but we need to recognize that the poorest countries will need help with that. Small countries like Luxembourg or Malta or Iceland, although they've done very, very well, but they will need some help with expertise as well. We're all in this together. And we need a global pandemic vaccine policy that enables us to get vaccines to everybody, because otherwise we will just have a constant stream of new variants, again putting us back into lockdown or imposing restrictions that none of us want. So let me conclude. None of this will be easy. And this will be a particular issue for the UK and some other countries, Russia, for example. Countries will have to accept that we're all in this together. They'll have to accept that we share sovereignty, that the solutions are common. We already do this in many areas. We have nuclear and biological weapons inspectors. We have strong rules in international finance. There is an international treaty on counterfeit banknotes. There is no international treaty on counterfeit drugs, even though this is a huge problem for antimicrobial resistance in many parts of the world. We recognize all of our rights and our responsibilities in the law of the sea. So why not in health? Health, I would argue, is too important just to be left to chance. So what I'm going to do is leave you at this point. We'll now have some questions, but I'd like to point you to some of our resources. I'm Research Director in the European Observatory and on Health Systems and Policies, a partnership of governments, international agencies and universities. And we produce this COVID-19 Health Systems Response Monitor, and we run regular webinars. And I hope that you will find some of them of some interest. And as I say, you can find the Monti Commission, the Pan-European Commission report on the website of WHO Euro. Thank you all very much.
I think we've just had a fascinating overview of Never Again. What a wonderful title, what a beautiful prospect. But I think we've now got the opportunity to ask some questions, and perhaps we should go first to ask, are there any on Zoom?
But before you do, can I just maybe make one point? And of course, as will be very apparent, I recorded my talk before the invasion of Ukraine. And in fact, this was probably a good thing, because over the past week, I've been extremely heavily involved with supporting colleagues there. Some of you may have seen the piece that we wrote in the British Medical Journal. And of course, our worst nightmares have been realized in that, with the Russian aggression against the Ukrainian people, and I can't obviously pass without condemning that in the strongest possible terms. We have many good friends in Ukrainian cities. I've been hearing horrendous stories all week. We've been helping with providing moral support, fundraising support, and so on. And so I just want to reiterate that, given that I sort of alluded to the risks involved there when I recorded my talk, but we clearly did not imagine that the horror would unfold at this level.
I think you kindly sent us sent me the BMJ article you'd written, and I think I can only really recommend it to everybody, and I hope we can circulate after the meeting for those who are here and those on Zoom, the links to it. You set the issues out very nice, well, sad and difficult issues, you set them out very well, and we'll try and make sure that BMJ article is accessible to those who've come to this lecture. Otherwise, I'll start with mine.
Ruth Anderson asks, it is politically so easy to quote unquote save money on public health, as it is less visible than a hospital. How do we combat this?
Yeah, you're absolutely right. And of course, we do know that there is nothing politicians like more than being photographed opening new things. And in fact, if you follow social media, you will see that 3 of the holders of the Great Office of State have their own photographers that follow them around at the minute, whether they're on driving tanks or standing in aircraft carriers or in front of flags. And I think that this is a real challenge. Public health is actually much less visible. But I think that the arguments have been made following the pandemic, at least in other countries. Now, fortunately, most of my work is not in the United Kingdom, but in other countries, what we're seeing with the French presidency of the EU, for example, in other countries where they are recognizing that investment in public health is part of national resilience, infrastructure development for crises, be they a pandemic. I mean, it is so obvious that our failure to invest in public health, our marginalization of local public health teams during the pandemic, just not making use of them, not making use of our existing laboratories, our veterinary laboratories, our NHS laboratories, but instead going for standalone facilities all of those issues really left us particularly vulnerable in the United Kingdom. So I think if you talk to people like Mark Carney, who I mentioned, I mean, I really would recommend his book. If you talk to people, the IMF has been a remarkable change. I mean, in the past, I've been very critical of the IMF. I've argued, we did work which showed how their structural, the various programs they ran in Africa had undermined the health infrastructure and created in some ways the condition for Ebola in West Africa in 2013-14. They're now changing their view. The OECD, we're working with the OECD to look at health resilience. The European Commission understands it. So I think in other countries now that is absolutely understood. There are particular problems in the UK. If anybody can find a thread of coherence in the last budget, I would love to know what it was, because it didn't seem to be, I mean, leaving aside the politics, you know, it's not just about cutting taxes. It wasn't even coherent in terms of promoting productivity. And we're also seeing in many other countries how they see the synergy between investment in public health and economic growth. Going back to the work that we did for the European Commission back in about 2004, 2005, that led to the slogan "Health is Wealth," and in the 2 ministerial conferences held in Tallinn in 2008 and 2018. So I think that the arguments get across elsewhere. I think that we do have a problem here, but you know, that's because I think of the nature of the political discourse in the UK, which doesn't really lend itself to careful deliberation.
Thank you. We have a few more. Sorry for the reverb there. We're trying to handle this. We have a few more questions via Zoom, if that would be okay. A question from Maggie Pete. Maggie Pete asks, why do you think we struggle so much to integrate health and social care?
Yeah, well, if you look at maybe the way of answering this is to look at the countries that do this much better. And that would be the Nordic countries, which have decentralized the health and social care budget. So they're basically run at the county council level or the municipalities in Finland, where they also bring in employment policies as well. So you've got a link across. Essentially what you have is a degree of democratic accountability there, where the government, the administrations at the county council are not having to worry about defence and foreign policy and things like that. They're worried about local economic growth, they're worried about health, social care and education. And therefore, because they don't have these other things to think about, they can put all of their effort into that. And, you know, they have control over budgets, they have tax raising powers. And I think that's why we do see greater links in Northern Ireland and Scotland in particular. So I think a lot of it is to do with the structure of local and regional government in the United Kingdom, where we still have this problem of a partial devolution settlement. I mean, we still haven't answered the West Lothian question that Tam Dael talked about. And of course, that is getting worse post-Brexit, because many of the powers that are being repatriated from Brussels that should really have gone to the devolved administrations are not going there. I think we're seeing some very imaginative solutions in areas like Greater Manchester, where you do have mayors who are trying to pull this together. But because of the problems we have, the disempowerment of local government that goes back to the 1980s, I think that's our fundamental problem in the United Kingdom. And, you know, the idea of elected mayors help, but it hasn't gone anything like as far as we would need it to if we were to emulate those parts of Europe where this does work quite well. Now, I can't hear anything else at the minute, but I can see some lips moving.
We have another question in the room. 1 second, we're having to come up to a microphone.
Yeah, that might be easier, thanks.
Hello, Martin. Thank
Hello.
you very much for the really good talk. Martin, I was going to ask you, one of the ways we ensure that never again happens is that we learn the lessons of what went well and what didn't go so well in how we handled pandemic. And if you were charged with setting up the inquiry into COVID-19, what are the key elements that you think would need to be in place to ensure we identify the lessons to be learned in a timely manner?
Well, let me just use this as an opportunity for a plug, because an independent SAGE, which I currently chair, our current Friday briefing sessions are actually looking at exactly this issue, and we're trying to set the agenda, or trying to contribute to the agenda for the inquiry, and we're having in discussions with the inquiry team about how we can help on that. I think one of the messages that I think will be very important is that there will be a natural tendency for people to say, well, it's easy with the benefit of hindsight. And of course, that is true. There are some things that none of us knew at the beginning of the pandemic. But I think what we will argue by pointing to the work that we and others did, and all of our reports are on our website, that many of the things that should have been done could have been done at the time. And I think the biggest issue, if I can boil it down to one issue, which I think transcends almost everything else, is that I think in the United Kingdom, we saw in an action what Sir Anthony King and Ivor Crewe described in their book, The Blunders of Our Governments. Going back to Douglas Jay's comments in the 1950s, the man in Whitehall really does know best. Now, in public health, we often talk about co-creation, co-production, working with people on the front line, people who are affected, working with patients to find solutions. What we see all the way through, from the marginalization of local public health teams to giving head teachers an instruction at 8 o'clock on a Sunday evening to be implemented at 7:30 on a Monday morning, through to failures described by people like Alan McNally and others, not to use the existing laboratory capacity, not to understand the challenges facing people living in disadvantaged areas, not to talk to local government teams and others. It has been this failure by central government to engage with those people who actually knew the practical issues involved and who were most affected. I think that I would like to think will come out as a cross-cutting, transcending issue that affects almost every aspect of the pandemic and why we failed. Where they did talk to people who knew, like in the genomic initiative, where the UK did very well, like getting Kate Bingham, who was, a venture capitalist, but knew how the system worked, how that aspect of making things work came about. That was a real success. So you got an expert. I mean, this is famously a country that's, quote, had enough of experts. But when they did get experts, then we actually did quite well. But the expertise doesn't have to be academic expertise. It could be local practical expertise. And I think we failed abysmally to do that, because edicts were coming out from Whitehall. And frankly, people were struggling to know, what do we do? How do you stay alert? How do you stay alert with an invisible virus? I mean, what do you do? You're meant to carry your electron microscope or your laboratory around with you. I mean, the whole thing just failed to grasp the lived reality of people's lives. And I would hope that that will be a key function. And it will actually address the whole process, much wider process of policy making in government. Because I work with many different governments in Europe. I work closely with ministers, with permanent secretaries in other governments. I advise them, and I have been through the pandemic. I work with international agencies. I can say from my personal knowledge that working with the United Kingdom government is by far the most difficult.
Very sobering thought.
We do have another question online. Yes. So a question from Anne Chamberlain. Saying your analysis is superb. What are our priorities?
What are our priorities? Oh God. The difficulty is that as of last Thursday, I think we in Europe are in a completely different ball game. And we have no idea what is going to be happening. As some of you know, I've spent 30 years working in the countries of the former Soviet Union. I know them very well. And I think we need to get through the current crisis. I think this will affect us in all sorts of ways. It's already affecting us. It's affecting supply chains. It's affecting energy prices. Many of you will have had new energy bills. Now, it's not just this, but this is going to make them even worse. I think that, it's really difficult to see beyond the next week or so the way things are going, because we are dealing with somebody who is so unpredictable, who has torn up the rule book, and where we don't have our own, we don't know how to cope ourselves. I think, you will have sensed from what I've said, I think the UK is increasingly isolated in this. Unfortunately, you really need to look at what's happening elsewhere. You know, I think we've got a lot of problems here at the minute. And while I think I've argued about the need for looking ahead beyond the pandemic, I actually personally think, and in my own work, getting through the next week or two is going to be absolutely crucial, I'm afraid.
I'm sure we're all wishing you the best for the week ahead. I think we're wishing that for everybody else. Do we have another question?
No more questions online currently.
Okay. Any other questions in the room? Otherwise, can I just ask, or take the opportunity to ask one final sort of question about vaccines, which you mentioned before. Is, in the light of what's happened with COVID vaccines, should the future development of vaccines be managed by companies or by governments or by WHO? So who actually owns the vaccines and therefore can dictate how they're going to be distributed?
Yeah, I think it has to be a partnership. It is a partnership anyway, but it's just an uneven partnership at the minute. It's a partnership because both Pfizer, BioNTech and AstraZeneca were largely funded by governments, and Moderna as well to a considerable extent. So that's where the money came from. So we would argue that that has to be done. Now, the difficulty then is, could it be done with COVAX, with the, you know, at an international level? Of course it could be, but countries have got to be willing to step up to the plate and provide the money. And there are a lot of challenges there because there has been a degree of vaccine nationalism, unfortunately. And, you know, it's not helped when some people want to put their own flag on their vaccine, for example. But I think getting the partnership right, and others have written about this. My colleague Els Torelli, for example, who used to head up the Access to Medicines work at the Open Society Foundation and at MSF, and Mariana Mazzucato, who she works with, in fact. So I think that there are lots of good ideas that are out there, but it is a partnership, but an equal partnership where each partner shares the risks and shares the benefits. And we need to do a lot more on health system strengthening to make sure the vaccines actually get out there. And of course, we need to confront the anti-vaccine narratives. And I have to say, the UK's approach to its failure, the delays in recommending vaccines for children in the United Kingdom has been a source of amazement to the rest of the world, who have been far in advance. So I think that while we did Kate Bingham, I really would congratulate Kate Bingham for her work on the vaccine task force. And it's interesting that once she stepped down, the whole program slowed, so that we're now well down the list in Europe. But you know, that was somebody who came from a business background, really knew what she was doing. But I think not everything has worked as well as it could have done in the UK, and particularly for children.
So you're leaving us with quite a challenge to go ahead. So I think at this point we should probably say, unless there's another question.
No questions online.
Can we say a very big thank you to Martin Mckee for giving us such a wonderful overview, so many challenges, so many problems. You've drawn our attention to the consequences of what's going on in Ukraine. There's going to be a lot to think about over the next few weeks, few months, and into the future. So I think we can say both to you and to Andy, who started this morning's lectures, can we say a very big thank you? We really do appreciate the time and the effort. And we know how busy Martin Mckee is. Well, I'm sure Andy's busy as well.
He is.
Thanks for all the effort to come and support us and to share with us. That's really appreciated. So can we just put our hands together for both speakers and say many thanks.